Hi everyone, I just wanted to do the video for the alcohol use disorder investigation, which is the topic that I chose for the final assignment around alcohol use disorder. So in the paper that I wrote and here in the video, I will investigate alcohol use disorder, its theorized etiology, treatment options, and my role as a future therapist in working with a client who's being treated with psychotropic medications for alcohol use disorder. So, substance use disorders, specifically alcohol, affects 5 to 10% of the adult population in the United States. As one of the most prevalent use disorders, it's likely that in my future practice, I will encounter clients who will be struggling with alcoholism. In addition, the prevalence of co-occurring psychiatric disorders within this population means that there will be additional layers of treatment methods to take into consideration. My own preconceived notions of the etiology behind substance use disorders provided an educational opportunity for me to see where my own biases were present. My effort in this paper in this video is to describe the theories of etiology, the psychopharmacological treatment options, and my personal role as a therapeutic catalyst in my client's road to recovery. So there are several prevailing theories on what the etiology of substance use disorders might be. Depending on the model viewed, there are different ways in which a clinician might treat a client. So throughout these different models, negative stigma remains one of the most significant barriers to treatment. In the moral failing model, the client is seen as weak-willed and should be punished. We've seen the byproduct of the moral failing model throughout history in the temperance movement, prohibition, criminalization, and the war on drugs. The addiction as a syndrome model is one of the simpler models where an equation of vulnerability plus exposure and access plus repeated interactions for desired effect equals addiction. In the maladaptive coping theory, substance use disorder is seen as a learned behavior from family, friends, and/or the client's environment. So the client was not able to learn adequate coping mechanisms. The disease model, which is accepted as the prevailing theory within the medical community and includes such programs as Alcoholics Anonymous and Al-Anon, is focused on biological factors and disease symptoms and complications. So typically there are higher rates of clients diagnosed with alcohol use disorder who have a family history of alcoholism than those who don't. Excuse me. The American Psychiatric Association states that the risk for developing alcohol use disorder is explained by genetic factors between 40 and 60% of the time. The rate of the condition is 3 to 4 times higher in individuals who have close relatives with the disorder. As it would pertain to vulnerability, alcohol use disorder is often co-occurring with other conditions such as schizophrenia, bipolar, anxiety and depression, and other behavioral disorders. The effects of alcohol use disorder in life functioning include impacts to health, school or work, familial responsibilities, and interpersonal relationships. As interpersonal relationships break down, they are further dissolved due to societal stigma reflected by fewer than 1 in 5 Americans being willing to associate with someone who struggles with a substance use disorder. Integrated treatment methods become really important to move client through not only the biological impacts of an alcohol use disorder, but also through the emotional and psychological components of the disorder, any comorbid psychiatric disorders, and the impact that they have within the life of the client. The first component to treatment would be a thorough assessment. So within the assessment, it would be important to separate out a potential diagnosis into components of the disorder such as dependence, abuse, intoxication, withdrawal, and persisting, all of which alcohol contributes to. In addition, alcohol has the ability to mimic other psychiatric disorders such as delirium, dementia, amnesia, psychosis, mood and anxiety disorders. Within each component of the alcohol use disorder, there's a different psychopharmacological treatment option. It's important to note that the diagnosis and treatment plan developed by the therapist be in conjunction with a prescribing psychiatrist or primary care physician through an integrated health model. So empirical evidence over the last decade suggests that this model provides the largest opportunity for successful treatment. The integrated health model provides alternatives to traditional single clinician outcomes that a client may experience. So when a client is working with only a mental health clinician, the clinician may be so focused on the training that they receive, but maybe not be specialized in substance use disorders. They might see behavioral problems related to intoxication or withdrawal as separate from the disorder itself, which could potentially worsen the disorder for the client. A substance abuse counselor has the experience of working within a specialized client pool, but may lack the necessary training that they need to adequately treat the client. They may believe that therapy won't solve the substance abuse disorder, and addressing that biological component of the disorder is all that's necessary. Conversely, a primary care physician is confident in science and tends to believe that they can diagnose as well as treat. The integrated health model solves to address these potential obstacles by combining the strengths of these professionals into a single solution that tackles all facets of the client's health. Within the psychopharmacological framework, the treatment options during the intoxication phase include supportive medications such as thiamine, folate, and multivitamins. During the withdrawal phase, benzodiazepines are the primary option. So benzodiazepines have applicable treatment efficacy for comorbid disorders such as delirium, delusional disorder, hallucinosis, and anxiety disorders. After the detox process has been completed, abstinence maintenance medications include antabuse, naltrexone, topiramate, acamprostate, gabapentin, lithium, and SSRIs. If a co-occurring mood disorder is present, an SSRI would address both. As a therapist working with a client that is currently being treated with medications for an alcohol use disorder, I would work in phases, with the initial phase being detox. This would assume that the client is open and willing to seek treatment. Post-detox, I would focus my treatment around the harm reduction model. So this model seeks to reduce the negative consequences of alcohol use disorder and reinforces the basic belief in rights and sovereignty of those who struggle with alcoholism. As a result, I would consistently make the effort to meet them where they are instead of reinforcing the cultural stigmas that possibly effectuated the disorder in the first place. This would require constant attention as to my own biases that may express themselves either explicitly or implicitly. The harm reduction model also recognizes that poverty, racism, classism, traumas, social isolation, and other social inequalities have real impacts on clients and their ability to avoid harm associated with alcohol use disorder and/or employ the coping skills necessary to manage an alcohol use disorder. Social inequalities mean that the client may need resources currently unavailable to them, such as housing, medical care, or social support. It would be important in my role to assist in providing access to services that provide these resources in an emotionally safe and supportive way. Also, as a part of the harm reduction model, there are types of therapies that would be employed within my treatment plan. So therapeutic models such as dialectical behavioral therapy, cognitive behavioral therapy, and brief strategic family therapy are all in line with the harm reduction model. When investigating alcohol use disorder in my education and around addiction and substance use disorders, I was originally confronted with my own preconceived notions of what creates an alcoholic. I understood the physical nature of an alcohol use disorder, but felt, much like Gabor Mate, that substance use disorder is always someone running from pain. What I found is that that's not always the case. As a result, my inclination to treat a potential underlying emotional problem is not the first move when treating alcohol use disorder. The client may simply be unable to handle this type of work without first detoxing and be far enough within a recovery period that emotional triggers have a reduced potential of relapse. Each client is unique, and in my treatment will require a unique approach. I've always felt resistant to working with this population type, but I feel that seeing someone succeed in recovery would be extremely rewarding through being of service. Johann Hari once said, "The opposite of addiction is not sobriety, it's connection." Thanks so much. Appreciate your time.